We're very fortunate to be joined today by Dr. Christine Ritchie, who will be speaking on exploring options as your condition changes. My name is Joe Costello. I'm an organizational consultant, a longtime clinical research subject and dementia volunteer, and a research ambassador, which I'll describe in a moment. My job here today is to welcome Dr. Ritchie and then to add a few comments about my own experience with research. Today's meeting is the latest in our Talk with the Doctor series. Each talk is given by an expert in some aspect of dementia and provides a chance for you to get your own questions answered. Talk with the Doctor is organized by the Research Ambassador Group, which is a volunteer branch of the Massachusetts Alzheimer's Disease Research Center, or MADRC as we call it. Our group here includes both past and present research study participants and their study partners. The Ambassador Program's primary purpose is to share current, explicit, and pertinent information from our own experience as research participants with others who might be considering taking part. We emphasize especially helping researchers to reach underrepresented communities. Quickly, before we begin, I want to mention a few housekeeping details. Please keep your microphones muted until it's time to ask questions. Be assured that you'll have access to a recording of today's meeting, so no need to take notes for friends or family members. You'll be able to send them a link. Also, no need to save your questions until the end. Just jot them down as they occur to you using the chat function on your Zoom screen. And now it's a real pleasure for me to introduce Dr. Christine Ritchie, who has graciously made time for us today in what I know to be her very crowded schedule. Among Dr. Ritchie's many appointments and responsibilities, she is a board-certified geriatrician and palliative care physician whose research focuses on optimizing quality of life for those with serious chronic illnesses, and she is the Kenneth L. Miniker Chair in Geriatrics at Mass General Hospital. And I personally appreciate the chance to work with Dr. Ritchie in her very important roles, first as co-director of the Outreach Recruitment and Engagement Corps at MADRC, which includes our Research Ambassador Group, and as a key member of the Massachusetts Governor's Advisory Council on Alzheimer's and all other dementias. Dr. Ritchie, thank you for being here. We all look forward to your presentation on exploring options as your condition changes.
Thank you, Joe, and greetings, everyone. It's really nice to be in this Zoom room together on this February 14th. And let me share my screen with you so that we can get started. All right. Are you all able to see my screen okay?
Yes.
Wonderful. Thank you. All right. So what I'd like for us to do today is first just provide a very brief overview of the dementia journey, because actually our understanding of dementia and how it unfolds is evolving. And I think it would be useful just to make sure we're all on the same page. And then talk about treatment options and support along the way, and specifically support as it relates to how we might integrate research participation and also engagement of other support and partners along our way in the dementia journey. So I want to start by sort of thinking about dementia and the stages of dementia and the dementia journey slightly differently than at least I was taught when I was in medical school a few years back. And that is that essentially our appreciation and understanding of dementia is that long before we start having any symptoms, we may be experiencing some preclinical changes in our brain that may affect our risk for or ultimate development of both mild cognitive impairment and dementia. And Risa Sperling, who is a really important member of our dementia research team here at Mass General Brigham, actually put this paper out in Alzheimer's and Dementia now, many, many years ago. And now we're seeing a lot to sort of suggest the importance of appreciating that this preclinical phase is an important phase. And I'd like to think about it sort of like we think about it, let's say with cardiovascular disease or heart disease, where, you may be having things going on in your body, either because of things that you eat or things that, or genetics or other things that may be affecting your cholesterol or other things that we know increase our risk for heart disease or the development of having a heart attack. And maybe not surprisingly, dementia is no different. We see this also with cancer. So we're beginning to appreciate that this time of sort of preclinical phase is important when people could be asymptomatic and they may have some biomarker changes that are suggestive of risk for the development of dementia, or they might have subjective changes where maybe a person notices changes, but nobody else does. Or they might even have some early symptomatic changes that don't still meet the criteria for mild cognitive impairment or dementia, but still are sort of in that early phase. And the reason I want to sort of call this to everyone's attention is because there is an increasing appreciation that this may be an important space for future treatments, because they may actually be able to keep people from developing dementia altogether, or at least reducing their risk in the same way that we see, especially in heart disease. So before we go too far down the path, I'd also like to talk about some definitions. I've already alluded to these, but I just want to make sure we're all on the same page. So first, we have subjective cognitive decline, and this is sort of, again, that place where we subjectively, so that's us as a person, start worrying about or noticing some changes, but they actually aren't picked up by others by and large. And while this may be a risk factor or indicator for the development of dementia, it may not be. Actually, the same is true for mild cognitive impairment. I'll talk about that a little bit more in a few minutes. But this is a type of cognitive impairment that is beyond what we would expect just based on age alone. And we'll talk about sort of what we often experience based on age alone, but is not interfering with our function. Like, we can still do our day-to-day things, and these cognitive changes are not interfering with that. When we actually develop dementia, and here it's described as Alzheimer's disease, which is a kind of dementia, that's when it actually has enough of an impact on our life that it's affecting function. And usually early on, it's more in sort of the thinking realm, where we may have troubles with our thinking. We may have mood changes. We may become a little bit less interested in things than we have in the past, or maybe more anxious in that early phase. And then in the middle phase, there's enough going on with our brain that we actually start having pretty significant changes. It may affect our ability to actually speak in the way we have in the past, think in the way we past, being able to process information, even be able to follow sometimes more complicated commands, process information. And in the late stages, it really affects our ability to even do things like perhaps walk around, engage in basic activities of daily living, communicate, and often we become much more dependent on others. So this is sort of a little bit more information about those different phases, and you can see there's the preclinical phase where there may be brain changes, but we don't have symptoms, then the mild cognitive impairment phase, where we have cognitive changes. Sometimes they may be noticeable to us. Sometimes they're noticeable to others who are with us. And then where we experience dementia is where we have, again, that impairment that's severe enough to really interfere with our ability to do things on the day-to-day. Now, before we go too far down the path, I think it's worth just again talking about dementia and recognizing that dementia is an umbrella term. It's used to actually describe, symptoms of a group of more than 100 different conditions that can affect our thinking, our brain-related behaviors, and our memory, and that is beyond, again, what we would expect from normal aging alone, and that also affects our daily function. I think of this sort of like we think about cancer. When people say they have cancer, it helps us know that there's a certain kind of thing that's going on in their body, but it doesn't tell us what kind of cancer it is. We need to have a better understanding. Is it colon cancer, or is it lymphoma, or is it leukemia? There are lots of different kinds of cancer. And the same is true with dementia, where we have vascular dementia, Parkinson's dementia-related, Parkinson's disease-related dementia, frontotemporal dementia, Lewy body dementia, Alzheimer's disease, all different kinds of dementia. And we're learning more about even other kinds of dementia as we learn more about the brain. Now, a lot of people say, well, look, I'm noticing some changes in my thinking. How can I know that this isn't like a harbinger beginning of dementia? And here are some things that can help you sort of differentiate. And that is that, you know, we all make bad decisions once in a while. We will miss things, if we're really busy or we're distracted or something else that's going on in our life. There are times when we may forget which day or week of the week it is, or what year it is. Say if we just moved from 2024 to 2025, we might still write 2024 on our journal entries. Sometimes we'll forget which word to use, or we have a specific word we really want to use, but we actually can only think of a word that's sort of a cousin to that. And then we may lose things from time to time. My personal example is my cell phone. My husband says that my dying words are going to be, "Where's my cell phone?" And that is because I put it down and then I run off and do other things, and I'm not attending to it. So we all have these changes as we age. Now, that's different than what we see in Alzheimer's disease, where it takes things to a new level, where we actually have trouble with sometimes our judgment or making decisions. This is where, again, people can actually be taken advantage of by scam artists who come in and say, you owe us a lot of money, you didn't pay this bill, and we may not have the judgment or the decision-making capability to recognize that actually it's a scam. We may have more difficulties managing budgets. An example of that I'll use again personally is that my father had dementia with Lewy body, and he was a brilliant person who was very good with numbers. And when he started having troubles with actually his budget and with numbers, I knew something was up. Losing track of the date or the season, having trouble with your speaking to the point where it's even difficult to have a conversation or to communicate what you want. And then misplacing things, being unable to retrace steps. And a lot of times what people experience with dementia is they start thinking other people actually took their stuff. So they're misplacing it, and there's misattribution also that can happen. All right, so now let's talk about these different stages that we've talked about, and go just a little bit deeper, because it's going to be important as we start thinking about treatment options. So as I've mentioned before, and this is really one of the big areas of growth, I would say, in our knowledge of dementia in science, is that there are all these new biomarkers that seem to be associated with the development of dementia that start increasing long before clinical symptoms. And again, I like to use heart disease as an example, because a lot of times, people will have elevated cholesterol for decades before they actually start having problems with, narrowing of their coronary arteries, so that they're risk for having a heart attack. Now, it's important to realize that we are seeing, and you can see now on the table on your right that comes from a paper that just came out last year, that there are a lot of different types of biomarkers that we're looking at. There's the amyloid beta protein. There's a ratio of two different kinds of proteins. There's a phosphorylated tau 181 protein. There's something called NFL, or what's often called neurofilament light chain. Hippocampal volume, which is something that we see on an MRI. And all of these changes often are seen long before someone develops dementia, but are associated in epidemiologic studies with the development of dementia. Now, here's the challenge. These changes in biomarkers are not consistently showing us that someone is going to develop dementia, but they are associated with increased risk. And in that respect, it's not dissimilar to what we see with heart disease, where someone who has an elevated cholesterol or an elevated low density lipoprotein, or LDL, are at increase for developing heart disease, but they might not. So that being said, if there's enough consistency, which we're beginning to see with some of the newer biomarkers coming out, it does appear to be an important target for therapeutic intervention. So if we can actually keep folks from developing dementia when we're still seeing these changes when someone's asymptomatic, that could be important. So that's a real area of active research right now, and something to consider. So when we think about options to consider in the preclinical phase, a lot of the things that we're thinking about are actually risk factor reductions that are not dissimilar to what we see with actually cardiovascular disease, because we do appreciate that part of what's happening for many different kinds of dementia has a vascular component to it and a vascular inflammatory component to it. And so the things that can reduce our risk in general for dementia include wearing helmets, because we know that trauma is associated with dementia. So if you're riding a bike, please wear a helmet. And because head trauma can increase our risk, making sure that our blood pressure is well controlled, or same with our blood sugars and cholesterol, engaging in healthier diets that are associated again with better vascular outcomes, exercise, social connection, including, interestingly, the use of hearing aids, and intellectual stimulation. And the happy thing about this is all of us can do this right now. So it doesn't matter who you are, what your age is, what your risk factors are. These are things that we can do right now. The other thing that we can do right now, and I think this is particularly relevant for people who know that they're at higher risk for the development of dementia, maybe because of genetic factors or because of their family history, is that they could participate in clinical trials that are actually trying to see if certain kinds of interventions or treatments can actually reduce someone's development of illness down the road. So here's an example of a prevention trial for your consideration if this is of interest to you and if you have particular reasons to believe that you're at increased risk for developing Alzheimer's disease. This is the Alzheimer's prevention trial, and in this trial, study participants have their memory performance tracked, and they are done everywhere. They can be done anywhere you have internet access, and they are looking to see what might be those things that are putting people at risk. And then if they look like they're at increased risk, then they're given opportunities to participate in some of these prevention-related trials. All right. Now let's go from preclinical to mild cognitive impairment. And as I already mentioned before, this is where people experience cognitive decline that's actually measurable. So we can measure it. It's greater than expected for someone's individual age and education level, but it does not interfere with their daily life. They're able to do still the things that they've done in the past. Now, from epidemiologic studies, we know that about 5 to 15% of people with mild cognitive impairment progress to dementia each year. So that clearly shows that there's increased risk for people who have mild cognitive impairment. However, there's 50% that remain stable at 5 years. And that means that not everybody who has mild cognitive impairment is going to move to dementia. So this is tricky because we know now that a lot of the interventions that we're going to talk about actually are often most effective for people with mild cognitive impairment, but it's tricky because not all people who have cognitive impairment are going to develop dementia, but certainly the risk is much increased compared to those who don't. Now, I want to provide just a quick caveat based on my own observations in clinical practice, which is that there are many people who've actually developed dementias. That is, their cognitive decline is measurably equivalent to having dementia, and it is affecting their daily life activities. And if you look on their medical record, it still says mild cognitive impairment. So I'm bringing this up because if, let's say, you're somebody who wants to be involved in a research study or actually want to consider some of the treatments that are currently now available for people with early disease or mild cognitive impairment, and you have mild cognitive impairment maybe listed in your electronic medical record, it doesn't mean that you have not actually progressed to dementia, because this term is used loosely in clinical practice. And it's important to have objective tests to make sure that it's still the case for somebody and they haven't actually progressed to dementia. All right. So what are some of the things that we should be considering in mild cognitive impairment? Well, this looks a bit the same as what we just saw with preclinical disease, doesn't it? Risk factor reduction and participation in clinical trials. That being said, there also are some new therapeutics that are also appropriate for mild cognitive impairment. Here are some of the clinical studies that are appropriate for folks with mild cognitive impairment. And I want to just highlight for you that if you go to this website, www.madrc.org, join a study, it is our effort to try to make sure that this website serves as a resource for you in identifying a study that might be appropriate for you, regardless of your stage or condition. As you might imagine, studies start, they conclude, and sometimes we may have a study on there that's concluded, and we apologize for that, but our goal is to make sure that you have opportunities to participate in studies if this is something that you care about and are concerned about. Now, why might it make sense to participate in a study if you either have preclinical disease or mild cognitive impairment? Well, we know from now a lot of literature that people who participate in research studies actually are more likely to get A, better care, and B, have better outcomes. And it's a weird thing, and my hypothesis is that it's from several different factors. One is that when you are close to the healthcare community, you learn about things that you wouldn't learn about otherwise. You develop relationships with people that you wouldn't necessarily develop relationships with otherwise, and that often gives you some additional access to both information and resources that you wouldn't have otherwise. There's also social connection that happens when you engage in research studies, and that also we know is associated with better outcomes across the board. And so there are reasons, a multitude of reasons, why thinking about participating in a study that works for you is worth considering. There are lots of different kinds of studies. So this first study that you see here, called the Memory and Aging Study, is actually, there's no interventions associated with it. It's literally just to follow people over time and to learn about sort of what happens to people's thinking and their brain health over time. Then these other studies that you see on here actually are looking at specific treatments. This one treatment called CD1812, really fancy name, is actually coming in the form of a capsule. It's only available inside a research study. And then you can see there's also some transcranial alternating current stimulation, which is now being studied and also has some interesting and potentially promising findings. There are a lot of studies that are like that. And so you can sort of decide what flavor might make the most sense for you. Now, I already mentioned before that dementia comes in many types. And the big thing when we start now moving from preclinical disease to mild cognitive impairment to dementia is that the big difference between dementia and mild cognitive impairment is that it interferes with daily functioning. And here from this slide, you can sort of see how common these different kinds of dementia are. Many people have what are called mixed dementia, where they may have both Alzheimer's disease and something else. And the most common form of mixed dementia is someone who has Alzheimer's disease and also has vascular dementia. All right, what are some of the things that we see in dementia? And some of these things we've already mentioned, but we see changes in brain mitochondria. We see changes for some people in terms of, or not changes, but we see risk factors associated with genetics, so that you may have heard of ApoE4, which is a gene that is associated with an increased risk for Alzheimer's disease. And then we also see something called epigenetics, which is a really interesting phenomenon where our life experiences, the environment in which we grew up in or that we live in, actually affects how our genes manifest themselves and how then they lead to the production of proteins that affect our daily functioning in our brain. It's probably some epigenetic changes that occur, for example, when people have traumatic brain injury that increases their risk for the development of dementia. People can have, depending on, again, the underlying etiology or cause of dementia, amyloid plaques, neurofibrillary tangles, and misfolded proteins. We know that inflammation and oxidative stress can also increase risk for dementia and manifest as dementia, along with vascular disease. And then we also know that your nerves, they connect to each other, and there's something called a synapse, which is essentially where information is transferred from one nerve to the other through neurotransmitters. That adaptability between the synapses and what occurs between the synapses is also important in both the development of dementia and how we treat dementia, as we'll talk about in a minute. So one important thing to keep in mind is that you won't know whether or not any of these treatments make sense for you unless you actually get a diagnosis. So how do you get a diagnosis? Well, for most people, and I've talked to a lot of folks who've been diagnosed with dementia along with their care partners, this can be a challenging journey. Because there's no single test that can diagnose dementia, and so it requires a combination of tests. Often this takes a while actually to conduct, because you have to make referrals, and it may take a while to actually get those referrals made, and then there's often a waiting list. But that being said, the common things that are done are cognitive testing, and for folks where maybe the cognitive testing is not showing something straightforward, more comprehensive neuropsychological evaluations, brain scans, and then a number of other tests that include genetic tests, testing of people's cerebral spinal fluid, and increasingly, most of this is still in the research phase, but soon I think we'll have blood tests that are potentially helpful for us as well. So why get a diagnosis? I think for most people, dementia is pretty scary. And I think there's a tendency to sort of have a don't ask, don't tell attitude about dementia. And yet there is real good reason to get a diagnosis. And here's one of the reasons, and the next slide will tell you some other reasons. So first of all, it's useful to know what kind of dementia one has, because some types of dementia are progressive and some aren't. So that's really important for planning perspectives and also for treatment perspectives. So if one is developing changes with their brain because, for example, they're having obstructive sleep apnea, which is quite common, that tends to be not progressive, especially if that obstructive sleep apnea is treated. There are also other things that can be more reversible that can be contributing to cognitive changes. And those things you'd want to know about so that those can be reversed. So that's one reason. The second reason is that it actually informs what you will do in terms of risk reduction and maybe how aggressive you are about risk reduction. It provides opportunities for you to participate in the studies we've been talking about. And then a big one, at least big for me, and I think big for probably many of you, is that it actually allows you to take control of your life in a way that if you don't actually have this information, you can't. So, you know, if you discover, for example, that you are developing dementia, then it becomes really important that you have also identified people who can potentially make decision makers for you when that day comes that it's going to be more difficult to make those decisions alone. Honestly, I think none of us know that we aren't going to get hit by a bus tomorrow. So I actually think we all should have decision makers identified, because there may all become a time when we have treatment decisions that need to be made where we can't make them. It's not only about identifying the decision maker, it's making sure that decision maker knows you well enough that they can actually make informed decisions for you that would be what you would want if you could make it by yourself. Also, financial planning and making sure that your financial situation is well attended to, thinking about future care settings. I think most of us are going to experience in our future life some level of need for support. 9 out of 10 of us, actually, before we die, will experience some kind of disability, and we will benefit from thinking now about what kind of care settings we'd like to consider for the future. And then finally, what kind of treatment decisions. So there's lots of good reasons for getting a diagnosis. And so if you're wondering, if you're worried, I would encourage you to actually go to the trouble of learning more of what's going on. We have a lot of resources through the Massachusetts Alzheimer's Disease Research Center about getting a diagnosis. We have these roadmap series, which you can find on our website. The Alzheimer's Association also has some really great information along with the National Institute on Aging. Now, there are a number of studies that are currently enrolling to particularly guide us around this whole diagnostic journey, because again, we're learning so much so quickly in dementia and dementia care that we're still needing to test and validate what we're learning to make sure that it's actually, valid and valid for all populations. So there are imaging studies that are out there. There are studies that help us understand which biomarkers are more helpful than others in terms of evaluating our brain and brain health. And then also learning about the natural history of cognitive changes. So what's nice about these studies is that there's no actual intervention involved, and increasingly these studies are providing information back to you as a study participant, so you have information you can pass on to your clinician. All right. So once you have a dementia diagnosis, then what are your options? So those other options that I mentioned in terms of risk reduction still hold, but there are now a whole new realm of options out there that I want to mention. I'm really going to focus on what is on the left hand of your slide and not on the right hand, but I do want you to be aware of these other as well. So on the right hand of your slide, for people who have symptoms, we often will try cognitive enhancers, and these are the ones that actually have been around for a while, and you may find are the first things that are recommended by your clinicians, what are called acetylcholinesterase inhibitors. That's what that ACHEI stands for. And the ones that are the most common are donepezil, rivastigmine, and galantamine. And then another cognitive enhancer, which is has a different mechanism of action, memantine. We also have symptoms that are more commonly developed as we develop dementia. And those symptoms can include anxiety and depression, or emotional lability. And for some folks, hallucinations and delusions that can be distressing to them. And for those, there are other medications that are often used. The more recent medications are these disease-modifying agents, which are called biologicals. They're currently, most of them are targeted at amyloid proteins in our brain. And you probably have heard of some of these: aducanumab, lecanemab, and donanemab. Aducanumab is not one that we recommend. Lecanemab and donanemab have more data to support their use. And while there is data to support their use, they also are associated with risk. And so, like practically all medications that are currently available to folks, it's important for you to know both the benefits and the burdens and make your own treatment decision about what is most aligned with your values. Lecanemab is probably was the first kid on the block to really be adopted more widely. It's a monoclonal antibody, as I mentioned, that targets beta amyloid, and it's administered intravenously. It requires infusions every 2 weeks, and the most common side effects are things like headaches, but the ones that people talk about the most are called ARIA, which is kind of a fancy name for an acronym that stands for amyloid-related imaging abnormalities. And the two most common amyloid-related imaging abnormalities are hemorrhage or bleeding in the brain, and swelling of the brain. The other kid on the block in this realm is donanemab. It is also provided intravenously. It's provided every 4 weeks for 18 months. And in a recent clinical trial, it was also shown to reduce the progression of cognitive decline and maintenance of independence and activities for a relatively modest amount of time. Again, there's almost exact same side effects for donanemab as lecanemab, with slightly different percentages for both brain bleeding and for hemorrhage. And ARIA, this amyloid-related imaging abnormality, is more common for people with the ApoE4, with the E4 variant of the ApoE gene. So I mentioned ARIA before. It's this edemas and microhemorrhages. And, this is one thing to know about imaging, is that it will often show us things that actually we don't know exist or that are there, but aren't actually having a negative impact. So there are a lot of people, 20% of people who are on these agents will have ARIA on imaging. It's the highest risk in the first 6 months. Most people are asymptomatic, but there is a meaningful subset who actually do have symptoms that affect their ability to continue with treatment. And there have been a few deaths documented. So these are not completely benign medications. The risk factors, as I mentioned, for ARIA are people who already had microhemorrhages in their brain to begin with, which is why an MRI is required before someone can be considered for these medications, have that E4 allele on their ApoE gene, and who are on blood thinners, which is why a lot of centers who provide these medications actually consider being on a blood thinner as a contraindication. I do want you to know about the MGB Alzheimer's Therapeutic Program. It does deliver these novel treatments, and they have sort of a 2-step process with eligibility determination and then safety monitoring. Now, across the board, I think it's important to realize that for early and moderate dementia, all the way through moderate dementia stages, cognitive engagement is really important in preventing cognitive decline. And this could be tough because for a lot of folks who are developing cognitive decline, it starts feeling more anxiety producing to actually engage cognitively. So you can almost think of it as like exercise, where sometimes you do it even though you don't feel like it. And cognitive engagement can mean a lot of different things. It can mean going to book club, going to a museum, connecting with others, playing an instrument, learning a new language, all kinds of things. But I guess what I'm trying to say is that if you're in that first phase of the dementia journey, you may not be thrilled about engaging in some of these cognitive strategies, and think of them like doing your workout. You're doing your morning walk. They're really good for you for your overall health and for your brain. Now, other treatment considerations besides medications to consider. I think in early disease, in addition to sort of thinking about the sort of medications, I think it's incredibly important to look candidly into the future and think about, okay, given what is likely to come down the pike, what can I do now to make sure that what happens to me in the future is going to optimize my quality of life and be aligned with my goals and values? And for a lot of people, this means connecting to dementia specialists, actually reading books and going to reputable sources on the internet. By the way, there are a lot of not reputable sources on the internet, so it is important to do that. And then to connect to support groups. And this can be important both for that person who's living with dementia and for their care partner. When we get into sort of the moderate phase of the illness, we want to start thinking about also our other comorbid conditions. So one thing to realize about people living with dementia is that most of us who are experiencing dementia don't just have dementia. We have other chronic medical conditions, and many times we're on those chronic on other medications and other treatments for those medical conditions. Sometimes the benefit burden ratios for some of those other treatments start to change, and it's worth really having candid conversations with your clinician about the benefit and burden of various types of treatments and different kinds of medications. At the same time, there may be new symptoms that are coming up that are important to manage. And for care partners, which is what CP stands for, they may also be experiencing their own distress and grief, and it's important to make sure that we're supporting care partners as well. In the middle phase of the dementia journey, it's really important to start connecting to supportive services, thinking about personal care aides, and also to connect to palliative care, geriatric care, both. Why? Because both these specialties are really about holistic, comprehensive care and not purely focused on just that one condition, but really how that one condition affects someone's total health and well-being. Now, I would be remiss if I didn't talk to you about other treatments that warrant more study, and I want to mention some of those now. So as you've seen, we're already down the pike on a number of amyloid targeting therapies and also tau protein targeting therapies. And a lot of the opportunities for studies that you're seeing out there are related to these kinds of therapies, along with vaccines. There's also some things that seem to affect sort of the health and well-being of our brain cells. And one of them that's getting a lot of increased attention right now is a medicine that's commonly used for diabetes called metformin. And in people with type 2 diabetes, we don't have, by the way, good data on people who don't have type 2 diabetes. But in people who have type 2 diabetes, metformin appears to potentially be effective at reducing risk for the development of dementia, or at least slowing its decline. So there's some interesting studies around metformin and other treatments that seem to affect sort of the brain cell health. There are a number of treatments now that were being considered for behavioral and psychological symptoms. And I would be remiss, and I think I see a colleague who certainly enlightened me a lot more about some of these alternative treatments without talking about some other treatments that are being evaluated right now, including electroconvulsive therapy, hypnosis, and mind-body interventions for symptoms associated with dementia, especially in the mid to latter phases. We need a lot more research in this space, and so please stay tuned, because I think there's going to be a lot more work being done there. And then digital therapeutics, there are increasing numbers of mobile apps, virtual reality, what are something called serious gaming, which is not gaming just for recreational purposes, but to actually improve health outcomes. And those digital therapeutics are also under study now. Want to finish by just sort of, again, reiterating for you that there's this Join a Study webpage that's out there for you and has a ton of great information, even if you don't join a study associated with the MADRC website. And then if you actually do want to consider research, maybe you haven't found the right study now, but you'd like to consider being asked about study opportunities in the future, consider joining our MADRC Research Registry. You're eligible to join if you're over 18, you live in Massachusetts. You do not have to have memory loss or dementia. You can, but you don't have to be a part of the research registry. We have just a whole array of studies available to folks. And when people are on the research registry, then it gives us permission to let other researchers know that you might be interested in their work, and they can then reach out to you. So just to summarize then, there are increasing numbers of treatment options for dementia across all stages of dementia. Ask your doctor and dementia care specialist for guidance. Don't go this alone. Think about participation in research and do stay informed and connected, because it really is a key to a current and future well-being. And with that, I'm going to stop sharing and look forward to answering questions.